would normally visualize the fluid and also lobar consolidation. So from the anterior axillary line, we would move the probe longitudinally towards the posterior axillary line, and then move it a little bit caudad until we see on the left side of the thorax, from caudad to cephalad, the kidney, the spleen, the diaphragm, and then the lungs. Now on the right side of the thorax, we will be able to see from caudad to cephalad, the liver, the diaphragm, and then the lungs. And so it goes. Now, there was another method which had been suggested by people from Italy, which is headed by Dr. Volpicelli. They showed this 12-point lung examination technique wherein they divided the lungs, the thorax, into 3 zones. The anterior zone is from the parasternal line to the anterior axillary line. The second zone, which is the lateral zone, is from the anterior axillary line to the posterior axillary line. And the third zone is at the back, which is between the paravertebral line and the scapular line. These zones are further subdivided into superior and inferior divisions. So we have bilaterally 12 points. Now, although the 6-point protocol, or what we call the blue protocol, would suffice in examining or trying to seal pathologic findings in the lungs, this group of people from Italy and China who have seen a lot of COVID patients suggested that it would be best for such types of patients to have a more thorough examination, since lung lesions would show up in any part of the lungs. And so in order not to miss any lung pathology, it would be best to adapt the 12-point protocol instead. Now, according again to Dr. Lichtenstein, we should be able to master several signs in order for us to determine how a normal lung looks like, and for us to be able to diagnose some pathologic findings based from these lung signs. So initially, for the blue protocol, if we place our probe at the mid-clavicular line between the second or third intercostal space, this is what we are looking at. This is our transducer. We have our skin and subcutaneous tissue. Then we have the pectoralis major muscle. And then below that, you will see the ribs. And in between will be the intercostal muscles. And below that will be the pleural line, which is composed of the parietal and visceral pleura, which for normal individuals, you cannot really recognize one from the other. You won't distinguish one for the other. And sonographically, this is how it will look like. You have here the skin and subcutaneous tissue. This is the thoracic muscle, the pectoralis major. Below that is the intercostal muscles. And between these intercostal muscles, you see these hyperechoic convex structures, which are the ribs. And below the ribs is an acoustic shadow. We call it an acoustic shadow because beyond the ribs, we won't be able to see anything. So it's completely dark. Now, between the ribs, a little bit lower, will be the pleural line, which is composed of the parietal and visceral pleura. And below that will be the lungs. So this is more popularly known as the bat sign. The ribs would connote the wings, and then the head will be the pleural line. The head will be the intercostal muscle, and the body will be the pleural line. Now, when we breathe, this is what we are going to see. You can see here the ribs, then this is the pleural line. It slides with respiration. And in that pleural line will be the sliding between the parietal and the visceral pleura against each other. Now, we are looking at it at the B mode. If we want to investigate more the presence of lung sliding, we can shift to the M mode. And this is how it would look like. This is better known as the seizure sign. Why? Because the thoracic wall is adynamic, so they call it as the ocean because the ocean is quiet. Well, the pleural line is this white horizontal line, which corresponds to the seashore, while the lungs, which is filled up with air, would be the sandy, granular beach. That's why it is called the seashore sign. So this connotes normal lung sliding. Now, this is how it will appear in the M mode. You can see here the thoracic wall. This is flat horizontal line because it is adynamic. Now, this is the pleural line, whereas This is the granular sandy beach, which connotes the lungs, which is filled up with air. Now we go next to the A lines. The A lines are horizontal hyperechoic lines that emanate. It means that there is the presence of air in the lungs. Now the fourth sign is the lung pulse. You can see here some small pulsatile movements. It corresponds to the contraction of the heart that can be conducted on the thoracic wall. If there is the presence of the lung pulse, it means that there's no separation between the visceral and parietal pleura. So you can completely rule out the presence of pneumothorax. Now again, this is in the B mode. We can study the lung pulse further in the M mode, and it would be shown as such. You can see these vertical lines emanating from the pleural line. These vertical lines are called P lines. And those connotes the lung pulse. The next would be the B lines. The B lines are characterized as it is a comet tail artifact. It is long, well-defined, hyperechoic. It would arise from the pleural line and ends at the bottom of the screen. It moves in concert with lung sliding. It erases the A lines. If there are one or two lines present in between the ribs, it would mean a normal finding. They're also called lung rockets. Now, if I may, let's have a little bit of a review. The lobule is the smallest lung unit, which is composed of an alveoli which is filled up with air, surrounded by the connective tissue which is called the interlobular septa. If this connective tissue is filled up with air, what happens is that this fluid becomes interspersed among a tetrahedron of air bubbles. So what happens is the ultrasound wave will be meeting up with this interface of air and water structure such that it will be reflected as streaks of white lines, which are the B lines. So the more fluid there is, the more B lines will be created. If there are 3 or more B lines between 2 ribs, then we call it septal rockets. The more B lines there will be, the lung density will increase, and there will be a decrease in aeration. So there can be a confluence of B lines, which are called ground glass rockets. Septal rockets or ground glass rockets can be caused by interstitial syndrome, which can be due to the following pathological findings. It can be due to cardiogenic or non-cardiogenic pulmonary edema. It can be due to acute lung injury, ARDS, pneumonia, pulmonary fibrosis, and interstitial lung disease. Now we go next to the lung point, which is another sign. Now, pneumothorax refers to the presence of air in the pleural space such that there will be a separation between the visceral and the parietal pleura. That point wherein the visceral and the parietal pleura would separate is called the lung point. Now, others would also call this as the pneumothorax border because it is the point wherein lung sliding would meet up at that point where there will be no sliding. So it will show as such. You can see here that there is lung sliding, but up to this point, you can see that there's no lung sliding. So others would call it as the pneumothorax border aside from lung point. So this is the 7th sign. Now we can further verify this by using the M mode. If the seizure sign would show us normal lung sliding, the stratosphere sign would show us that there's no lung sliding. They're all horizontal lines because it means there's no lung sliding, so it is adynamic. This is how it would look like in the M mode. So you can see here that there's no lung sliding in the pleural line. And then in the M mode, they're all horizontal lines. Now we go to the 3rd zone in the blue point, wherein we put our probe longitudinally at the Phillips point, or others would call it as the costophrenic angle, which is the most bottom part of the lungs. This is where we observe most commonly lung consolidation and also pleural effusion. Now, again, looking back at the right side of the thorax, you'll be able to see the liver, the diaphragm, and the lungs. And then below the liver, you'll be able to see this vertebral column. Now, it does not go beyond the diaphragm because the lungs will obscure the vertebral column beyond the diaphragm. Now, when we breathe normally and our transducer is at that Phillips point, when the person would inhale, you will see that the lungs will move beyond the diaphragm and the liver. You can see here the vertebral column, which does not extend beyond the diaphragm. So we call this as the curtain sign. Okay. Now, if we see a pleural effusion, it is usually between the diaphragm and the lungs. It appears as an anechoic area between the diaphragm and the lungs. And since the fluid is a very good transmitter of the lung waves, you can see the vertebral column now beyond the diaphragm. Normally, if there's no fluid, you can only see the vertebral column up to the diaphragm. But now you can see it beyond the diaphragm. This is called the spine sign, which shows pleural effusion. Now, this is how it would look like. This is the left side of the thorax. You can see the pleural effusion between the diaphragm and the lungs. This is the kidney, the spleen, and then you can see this anechoic structure here, which contains pleural fluid. You can see the vertebral column under the kidney and also the pleural effusion. So next, we go to the last sign, which is the tissue sign. If there's a translobar consolidation, the alveoli becomes filled up with a lot of water, so that the lung parenchyma would have a structure similar to that of the liver. It becomes hypoechoic and solid, very much like the structure or how the liver looks like. So this is called lung hepatization, or others would call it very commonly as the tissue sign. I'm almost done. Now, this is a sample of a lung signs matrix. Based from all the signs that we have studied and I have showed you and enumerated, we can come up with the following diagnosis based from all of those lung findings. Now, before I end, this is some food for thought. In the perioperative arena, point-of-care ultrasound may benefit the patients preoperatively, intraoperatively, and postoperatively. The development of a comprehensive focused curriculum to help the residents master this new technology will surely advance the skills of tomorrow's anesthesiologists. Thank you. Okay, Mickey, I'm done.
Okay. Okay, thank you very much, Dr. Cano, for that very informative lecture. And you have pretty good visuals, and you were able to discuss a lot of the basics that a lot of the anesthesiologists here in the Philippines and maybe some parts of the world will benefit from. Okay. Now, we have another speaker. Allow me to introduce our next speaker. I will consider our next speaker a hero, because when he's not giving anesthesia, he was able to treat a lot of patients in the front lines of New York. He happens to be an associate professor at the Department of Anesthesia of the Columbia University Medical Center. And he happens also to be a director of the post-anesthesia care unit of the same institution, and at the same time, a director of the perioperative ultrasound of the Department of Anesthesia of Columbia University. He's a member of the Division of Critical Care and Regional Anesthesia of Columbia University as well. For those of you who attended, I think, the PSA, Philippine Society of Anesthesiologists, ISURA convention last year.